All right. Welcome, everybody, to Cardiovascular Medicine Grand Rounds. It is my pleasure to introduce today to our speaker, Dr. Tanuka Datta Piech is a general cardiologist and echocardiographer who recently joined Michigan Medicine in September of 2023. She received her bachelor degree and medical degree from Wayne State University. She completed her internal medicine residency training at George Washington University in Washington, D.C., where she also served as a chief medical resident. She completed her fellowship training in cardiovascular medicine and advanced echocardiography at Thomas Jefferson University in Philadelphia, where she also served as a chief fellow. She currently sees patients at Brighton Center for Specialty Care in the cardiology clinic and attends the echocardiography laboratory in the cardiovascular center at Michigan Medicine. Dr. Piech's clinical interests include assessment of PFO morphology using 3D transesophageal echocardiography, as well as medical education. Outside of work, she enjoys running, ballet, and spending time with her family. During her short time at our institution, I can tell you she has shown a phenomenal team player approach. She's also shown to be a caring and thoughtful person, and we are very grateful she decided to join our team. She's going to be talking today about the whole truth, standardizing anatomic nomenclature and novel sizing concepts for transcatheter PFO closure with 3D TEE assessment. So please help me welcome her.
Thank you so much, Victor. And thank you all for allowing me to present today. I'm doing so from Brighton, so apologies for the virtual approach to this. I'm delighted, however, to share with you all my niche in echo, which I fell into during my fellowship, and I'm so glad that I did. And that is having to do with PFO, and specifically utilizing 3D TEE when it comes to standardizing anatomic nomenclature and developing novel sizing concepts for transcatheter closure of PFO morphologies. Some of you may have heard part of this talk during my interview here, but today I'm going to expand upon those concepts and also present with you some data. So to start off, I have my objectives today are to refresh your knowledge first and foremost. Sorry for the technical difficulties. My objectives today are to refresh your knowledge on clinical indications for PFO closure. I hope that you gain an appreciation for PFO morphology, understand the instrumental role of 3D TEE in standardizing anatomic nomenclature and device size selection. And then I'm going to present some clinical outcome data to you that supports our novel concepts and sizing techniques. So let's first start off with what is a PFO? And I do apologize to my congenital colleagues who probably think this is an oversimplification, but we all know that, before birth, a PFO is completely normal in order to facilitate oxygenated blood travel from the right atrium to the left atrium in the fetal heart. After birth, of course, this physiology changes and the PFO naturally closes. In a third of the population, however, this doesn't occur, resulting in a lifelong PFO. And as one of my colleagues here actually pointed out to a patient, it's a lot like being left-handed. Thank you, Troy. I think this is a wonderful analogy for patient education because really it's not anything to be concerned about unless you have certain factors at play. I did, however, look up the statistics and only 10% of the population is left-handed, but nonetheless, a wonderful educational tool. So what I do want you to appreciate is that the PFO is not just any old hole. It's actually formulated by a tunnel from a flap-like thin septum primum and a thicker septum secundum. And it's anterior-superiorly placed within the interatrial septum. That's how it opens. The left atrial opening is adjacent to the aorta and the superior vena cava, and typically crescenteric in shape. However, it's not just that slit. It's actually more consistent with a coin slot. So if you look here, the septum primum would be that thin portion of the coin slot, while your septum secundum is this thicker portion. In the heart, this is what it would look at, so somewhat upside down, but that gives you a good analogy for what to actually think of when you're looking at a PFO. PFO anatomy can be highly variable. There's different sizes, different degrees of physiologic significance, and although in normal physiologic conditions, the left to right atrial pressure difference keeps the tunnel closed, it would prevent communication between the two atria. But at times, right to left shunting can occur due to conditions that increase the right-sided pressure. And this can manifest with patients exhibiting intermittent or continuous left to right shunting. So let's say you've identified a PFO. Who needs actual a closure clinically? Well, the indication we're most familiar with is that of cryptogenic stroke. Initial randomized control trials, those being Closure 1, RESPECT, PC, demonstrated initially no benefit from transcatheter closure. But long-term follow-up on the order of about 10 years from several of these trials now demonstrate superiority of PFO closure versus just medical management. Another indication is platypnea orthodeoxia syndrome, which is the opposite of orthopnea. You're short of breath when you're sitting up rather than laying flat. Oftentimes, this is clinically seen in patients that have some degree of spinal pathology, kyphosis, or something of that nature. Decompression syndrome in deep sea divers. And then there was some observational data that was promising. However, randomized control trials in the MISS study was negative for migraine headaches being an indication for PFO closure. Now, if you do identify a patient that needs closure, particularly in the cryptogenic stroke realm, there are two devices that were approved for closure by the FDA. The one is the Amplatzer device in October 2016, gained FDA approval. And the other is the Gore PFO occluder device, which gained FDA approval in March of 2018. So let's look at the Amplatzer device a little more in detail. It's a self-expandable double disc device that's made from a nitinol wire mesh and a thin polyester fabric. There's two discs that are linked by a short connecting waist. And in all of the devices, aside from the smallest, which is the 18 mm device, the right atrial disc is larger than the left atrial disc. The device is named based on the right atrial disc size, and selecting the proper disc requires quite careful evaluation of the PFO itself. So when we're looking at a PFO for pre-closure, there's a number of factors at play. First and foremost, of course, the presence of a PFO and an atrial septal aneurysm. And I will take a pause here to say that for patient education, whoever named this, hypermobile active atrial septum as an aneurysm clearly did not have an Epic inbox, because the number of patient calls we get after an echo that says, oh my gosh, my echo shows an aneurysm is quite comedic these days. But regardless to say, I digress. It is important to identify it because it does have an independent risk with stroke and also is closely associated with PFO. And this can be seen by agitated saline with a contrast study on transthoracic echocardiogram. You also then want to assess the degree of shunting by color Doppler and agitated saline, and this can be done with rest or also encouraged to do with provocation. Provocation is anything that increases the right atrial pressure. Valsalva maneuver, most often used. And then there's a number of anatomic features to be cognizant of when you're looking around the PFO and at it itself. One can be a stretched PFO, which is essentially a defect with shunting at rest. You also then, as I mentioned before, want to look at that interatrial septum to see if it's hypermobile or if it's actually aneurysmal. And then look at that septum secundum. Is it thick? Is there lipomatous hypertrophy? Is there a prominent eustachian ridge surrounding the area? All factors that would come into play to try to assess for successful closure with the device. There can be hybrid defects, a concomitant ASD, or a rare double orifice PFO, which is essentially two tunnels within that PFO. And then what I want to concentrate more on today is sort of the concept of sizing the PFO itself. Traditionally, tunnel type or tunnel length has been the parameter that we look at. There's a short tunnel type and there's a long tunnel type, 8 to 12 millimeters sort of being the cutoff. And this traditionally affected the choice of device type. But we showed, along with other colleagues recently, that PFO tunnel width, a dimension that you may not be as familiar with, is actually more indicative of true PFO tunnel size. And I'm not surprised that it might be a dimension you don't really know about, because certainly the device size manufacturers don't really take it into account. Currently, PFO closure device sizing in the instructions for use take 3 factors into account: the tunnel length, the severity of the atrial septal aneurysm, and the thickness of the septum segundum. However, it's much more complex than that. And these 3 things don't truly depict the tunnel size, so to speak, for successful device selection. So herein lies the problem. We know that in patients who are amenable to transcatheter PFO closure, proper defect sizing and appropriate device size selection are imperative to ensure successful procedural outcomes and prevent recurrent strokes. However, PFO sizing for device selection is highly variable. There's multiple methods that are being utilized in clinical practice. And that is in part due to the fact that nomenclature for PFO size remains unstandardized, and it continues to be based primarily on 2-dimensional imaging, despite our improved understanding of PFO morphology from 3-dimensional TEE. Furthermore, residual shunting remains as high as 25%, and that's associated with a 3-fold higher risk in stroke, or TIA, after device closure itself. So with increasing numbers and types of devices that are being utilized for PFO closure, standardizing this terminology and imaging techniques are necessary not only to ensure proper assessment of the PFO in clinical practice and trials, but also facilitate communication between cardiovascular specialists, and of course, ensure optimal clinical outcomes. So what can we do about it? Well, first and foremost, it's important to standardize this terminology. And so we proposed a standardized terminology in the table that you see here of 3 different dimensions. Traditionally, what you know as the tunnel length, and if you follow my arrow, hopefully you can see, that is this horizontal dimension here. To kind of put you into reference in figure A, this is a 3D rendition of a bicaval view with a transesophageal echo image. The right atrium is down here, the left atrium is up here. This is your septum primum, that thin flap-like crescenteric structure. And this is your septum segundum, that thicker structure that goes under in much of a donut shape if you think about it 3-dimensionally. The tunnel length is described as the distance between the right atrial opening at the fossa ovalis and the left atrial opening of the PFO, this horizontal dimension here. Now, one of the pitfalls of this is, if you remember, this is a coin slot. The left atrial opening, or this septum primum, is actually crescenteric in shape. And so if your 2-dimensional cut is after the crescenteric shape in one of the arms of the C, you may be artificially measuring a longer tunnel length than what is actually true. So coming to the 2nd dimension, which is the vertical line, the tunnel height, represented with my arrow here, hopefully you can see in figure A as well. This is the separation between the septum segundum and the septum primum, or the minor axis of the oval-shaped opening, if you will. Now, this dimension is quite dynamic. As you recall, normally left atrial pressures are higher than right atrial pressures. And so it's very difficult to catch this opening, so to speak, as the cardiac cycle varies. Valsalva maneuver, of course, can increase your chances of opening it up and actually measuring that successfully. The 3rd dimension, which we are introducing as the novel and important dimension, is this tunnel width, or the opening from the right atrial side and the opening at the left atrial side. What I want you to do for this dimension is imagine that you're standing in the right atrium down here and looking en face into this tunnel, staring straight at it. What you will then be staring at is the figure B over here, which is the opening of this tunnel from the right atrial side, the tunnel width, or the lanes in the highway, so to speak. And concomitantly, if you stand on the left atrial side, look into this tunnel, you're going to get the tunnel width at the left atrial side. Now, these tunnel widths are better visualized with biplane or 3D TEE. And it's easier, of course, to make when the septum primum is separated from the septum segundum. Specifically because the left atrium is crescenteric in shape, which I pointed out, we measure the left atrial opening from the point where the C is at that C, the pinnacle of the C itself, to actually say that's the width of the LA opening. If you measure it anywhere else, you may not have that roof, and you're not going to actually have the roof over that left atrial opening intact. So with that in mind, I'd like to walk you through 2 cases that were seen at our institution that demonstrate the importance of this width in proper device selection and tunnel sizing. The first is a case of a 66-year-old female who presented with a past medical history of high blood pressure and breast cancer. She had symptoms of slurred speech and a headache. Her MRI showed an acute right cerebellar infarct. CTA of the head and neck showed no large vessel occlusion. Her lower extremity ultrasounds and MRV of her abdomen and pelvis did not show a DVT, so she was diagnosed with cryptogenic stroke. A TEE was performed, and it was noted that she had a large PFO and atrial septal aneurysm with bidirectional shunting by color Doppler. A loop recorder was placed. It showed no evidence of atrial fibrillation, and as such, she was referred for PFO closure. What we see here is the rendition of a three-dimensional bicable view from 90 degrees, if you're familiar with transesophageal echo. And this shows you the PFO tunnel length by the horizontal white dotted line and the tunnel height by the vertical white dotted line. And these measurements came out to length being 10 millimeters, PFO tunnel height being 7 millimeters. Not too big based on these measurements. However, the PFO tunnel width, that is the size of the opening as seen on FOSS from the left atrial view, was much larger. It was 22 millimeters. If you hadn't had this dimension, you probably would have picked a sizing device that was more in count with your tunnel length and your tunnel height. We can look at this right atrial opening a little better with the moving images just to gain your appreciation of sort of the complexity as well as how much that height actually changes with respiratory variation in cardiac cycle. And similarly, we see here the left atrial opening side. And so based on those initial measurements, I should say based on the atrial width measurement, the width of the LA opening, a 35 millimeter device was selected. And you can appreciate that it was well seated and there was no shunting residually with a bubble study afterwards. On the left here, I want you to also appreciate this view of the occluder device and how it is in reference to the right atrial width and the left atrial width. You can see that the device, this is the right atrial disc, centers around the right atrial width. And if you were to take this blue measurement into account, which would have just been your tunnel length, this device seems much too large for that. However, knowing that the width was actually larger, it no longer seems like it's an oversized device, if you will. That takes me to case 2. This was the case of a 49-year-old male who had a history of high blood pressure, hyperlipidemia, presented with aphasia and right-sided hemiparesis. An MRI showed a left MCA stroke. He was given TPA, underwent a mechanical thrombectomy. A TE was eventually done, which showed a PFO with an atrial septal aneurysm. He had hypercoagulable testing, which was negative. A loop recorder was placed, no atrial fibrillation found, and thus he was referred for PFO closure as well. Some images to share with you about this case. You can see the 3D TE image here demonstrating a rightward displaced septum. So on first review, this goes back to what we had mentioned prior. The left atrial pressure is generally higher than the right atrial. So you may not actually fully appreciate the tunnel length or the tunnel height with just this image alone. And it almost looks like there may not be a PFO. In this case specifically, we utilized the concept of wire sizing. So during the procedure itself, a wire was placed between the septum primum and secundum to better open up the tunnel itself. And using this, we were able to then say, well, it looks like the tunnel length is 2 millimeters. The tunnel height is 2 to 3 millimeters. And the tunnel width at this point ended up being 15 millimeters. Because the tunnel length was quite short, the opening at the right atrium and the left atrium was similar. And this I should actually backtrack and say was just provocation maneuvers, not yet with the wire sizing. The next image that you see, which you'll see here, was with the wire sizing. And what I want to demonstrate here is that with the wire passing through, the PFO tunnel width, instead of being 15 millimeters, actually ended up being 20. So it was much larger. Now with that initial width of 15, we said a 25 millimeter device would do it. And because with the wire, there was no change in the tunnel length or the tunnel height, the team stuck with a 25 millimeter device. And this was the result. Which you can see, hopefully, that the 25 millimeter PFO occluder device is not well seated. It is not sitting well on this inner atrial septum, and thus was not the right device size selection. So it was taken out, and a 35 millimeter device was placed instead. And you can see much better results. well seated, no residual shunting with bubble study. So with these cases in mind, we decided to look at all of the PFO closures that we did at my prior institution. Since 2017, we had been utilizing this concept of the RA tunnel width in sizing our PFO and then further selecting our devices. And we put all this together and came up with an abstract that we presented at ASC just in June. And it was utilizing basically the superior PFO sizing method using three-dimensional TEE to incorporate this dimension of right atrial tunnel width into PFO sizing. And with this context, we then went a step further and developed what we call the PFO cover index. Specifically, 64 patients at our institution had undergone transcatheter PFO closure, 60 of which had utilized 3D TEE-based RA tunnel width oversizing in terms of the strategy. And we then went to have some statistical analysis done using correlation analysis to determine the relationship between PFO tunnel length and width. And we found this, that tunnel width at the right atrial opening or tunnel width at the left atrial opening had no significant correlation with tunnel length. So you could have somebody that has a tunnel length of 2 millimeters, like I demonstrated before, and think it's a small tunnel, but in reality, their width might be 22 millimeters, and that's actually quite a large PFO. But furthermore, tunnel width at the left atrial opening and tunnel width at the right atrial opening did show good correlation. So this is probably a much better predictor overall of your actual PFO size. Now, taking that even a step further, if you remember, looking at the right atrial opening in this schematic on the left here, it centers right over the right atrial disc. So your blue arrow is representing your PFO tunnel width, and this arrow underneath is your RA disc diameter. And the concept then that we developed with this in mind is that of a PFO cover index. Now, many structural devices have defined result parameters that confirm deployment success, or at least predict deployment success. For example, the Watchman refers to a percent of device compression. CABI has a true cover index that is predictive of, residual aortic regurgitation, but no such thing develops for a PFO yet. And so the PFO cover index is simply just the difference between the RA disc diameter and the RA tunnel width. And the red portion of the arrow that you see with the RA disc diameter is that amount of oversizing that we are looking at in terms of that cover index to predict successful closure. And so what we did with that is then looked at, we know successful closure for a device should ideally result in minimal or residual shunting or no shunting on long-term follow-up echo. So we used that parameter to define clinical success. And we conducted an ROC curve analysis to determine the predictive ability of this PFO cover index to predict residual shunting at follow-up. We found that of the 3 parameters with 3D TEE to define PFO tunnel size, that being tunnel width, tunnel length, width at the RA opening, or width at the LA opening, only the tunnel width at the RA opening was predictive of a residual shunting at follow-up. And extrapolating that further to the PFO cover index, this was also strongly predictive of residual shunting at follow-up. You can see here the area under the curve, 0.88, and a p-value of 0.002. This is unpublished data, but is to be presented at AHA this year, next month. Now, we also found that specifically a cover index of less than or equal to 9.5 millimeters or less had the best combination of sensitivity and specificity. What does that mean clinically? So that essentially means that if you oversize your device by 9.5 millimeters in reference to the width at the RA opening of your PFO tunnel, or better said, 4.5 to 5 millimeters on each side, you should have less residual shunting at follow-up and better clinical success in terms of predicting successful closure. And so the cases that I shared with you earlier that, sort of highlighted this concept and went through it to demonstrate the importance, we did publish in a case report about a year ago in November in Case. And then this concept of the PFO index predicting residual shunting after transcatheter closure, I will be presenting next month at AHA. So if you are attending, please stop by the poster and show some support. So in summary today, I hope that I have refreshed your knowledge on clinical indications for PFO closure. I hope you've gained an appreciation for PFO morphology, more so than just, a hole in the heart. I hope that I've convinced you that terminology for PFO tunnel sizing still remains unstandardized, but should be standardized, and that device size selection for transcatheter PFO closure is highly variable. Tunnel width measurements may actually be a better descriptor of PFO tunnel size, and that this PFO cover index that we propose based on the RA tunnel width is more predictive of residual shunting after PFO closure to ensure successful closure success. So where do we go next? What are our future directions? Well, I hope that we can propagate the use of standard terminology for PFO dimensions within the echocardiography and structural interventional community. I hope that we incorporate PFO cover index into routine clinical practice over time, and that we continue to study PFO morphology with 3D TEE for sustained success in device size selection and effective closure techniques in the future. With that, I would like to thank my mentor over at Thomas Jefferson University, Dr. Praveen Mehrotra, who's the director of the echocardiography lab. He's been an amazing mentor, a fantastic colleague when I transitioned over to being an attending for the first time, really taught me everything about advanced echo and specifically for this project. So thank you to Praveen. Here are a couple other references with this project, as well as some of the concepts that I refer to. And I'd like to end on a note. This is my 2.5-year-old son. I know I have not been able to meet all of you, and he did not meet many of you at the picnic. In the picture here, we hope that he becomes a physician someday, or maybe a professional bingo tallier. I don't know, to be decided. We'll be proud other way. That was short, but anybody with questions, anything to share, I'd be open to taking comments.
All right, thank you, Tanuka. I think that was a phenomenal presentation and very educational for sure. Dr. Pinsky has a question, and let us know if you can hear the questions. First of all.
Sure.
So first of all, that was fabulous, and I really love the fact that your work is leading you to change the guidelines and how we practice. So that's just terrific. Question. Sizing, it seems like it's all the undersizing is a problem for the reasons you articulated, but there's a lot of room in the atrium. Why don't we just oversize everything?
Yeah, so great question. There is a number of factors that we have to look into. So if you do oversize, you can impinge against the roof of the left atrium or the right atrium. And that can certainly be a problem because it can cause to erosion. It can cause, effects structurally within the heart itself that obviously would be more problematic than helpful in terms of closing that PFO. So there's also a specific amount of room that you have to target within that interatrial septum to cover the PFO, but not impinge upon, the aorta or impinge upon the roof at the top.
Thank you.
Rodrigo?
Thank you very much. I learned a lot. I really appreciate your talk. It seems to me like oversizing could create hemodynamic trouble for the atria, that atrial function could be affected by that large rigid disc in there. And I guess my question is, when you look at the trials comparing surgical closure to PFO with devices, is there any signal that AFib in long-term follow-up is less if you just stitch this together than put in a device? Do you know about that?
That's a great question. I do not know the answer to that. I will certainly look at the literature because that I'm sure has been looked at least some parameter of success based on transcatheter closure or surgical closure. Specific to atrial fibrillation, I do not know. I'm not sure if anybody else in the audience with maybe a little more experience in that follow-up has insight.
We're all equally ignorant.
Well, like I said, I have some homework to do.
Tanuka, I have a question for you. Of the 3D assessment with transesophageal echocardiography, I find the interatrial septum to be one of the toughest. And, it's thin, it moves. and you want to adjust for frame rates, and the patient has an irregular rhythm. Can you share with us some of your kind of technique approach, and what do you do to get a good quality image with 3D echocardiography?
Absolutely. So first off, using 3D is very helpful for that interatrial septum, especially to get that right atrial and left atrial width opening. You want to make sure the patient is as hemodynamically stable as possible going in. So atrial arrhythmias can certainly affect that opening and that separation between the septum primum and the septum secundum. Of course, if they're hemodynamically unstable, you're probably not going to do the TE in the first place. But regardless, what we tend to do is reserve that PFO and that interatrial septal assessment for a little after, midway during the study, so that you're not necessarily trying to get it when the patient is first sedated and first undergoing, a lot of those hemodynamic changes. And then on top of that, I think it's very helpful to look at that septum and that separation with the provocation maneuvers. So increasing right atrial pressure with Valsalva will definitely bring out that interatrial septum. And although it is difficult to see, that 90-degree bicaval view, generally speaking on TEE is seeable. You can get there. Obviously in a transthoracic, we don't get a good image of the interatrial septum at all. But I would say definitely making sure that you get that good Valsalva, and abdominal pressure is one thing that you can do. You can have anesthesia oftentimes help as well to increase right atrial pressures. And then a bubble study, if you're at the end really not seeing anything at all just by color Doppler, is also extremely helpful, both for the pressure aspect of the bubbles going through, as well as being able to actually visualize how many of them are passing and if they're actually going through that PFO.
Yeah, Ted, Dr. Collius.
Hi, Tanuka, Ted Collius. A really nice talk. You did a really nice job showing about the importance of sizing of the PFO. Are there other additional factors that you also factor in that are anatomic, both with the location of the PFO and also anatomic factors of the septum itself, such as if it's a lipomatous intraatrial septum, or if the PFO itself is located very close to the aortic root? How does that impact the recommendations you make?
Yeah, so generally, your ridges you normally look at for, ASDs. In PFOs, personally, I haven't come across too many where you're running into being too close to the aorta. It can certainly happen, but when you're looking at that septum and really interrogating it, yes, you want to make sure that anatomically it's in a spot that when you put that device in, you're not going to impinge on any factor, whether that's the roof of the right atrium or that's too close to the aortic ridge itself. And during the actual intervention itself, you get the device and you deploy it, and then you also look very carefully to make sure you're not impinging on things. Other anatomical structural things that you look for, in addition to just the sizing, are, as you mentioned, thickness of that septum secundum or lipomatous hypertrophy. That's actually one of the things that are in the instructions for use for the actual closure devices. The interatrial septal aneurysm, that can also be something that if it's too aneurysmal, does come into account in terms of being able to successfully close or not. And then if you have any other associated pathology, so you can have a concomitant ASD with a PFO, that becomes pretty difficult in terms of sort of where it's anatomically located, because now you have a larger or many defects to try to attempt to close, which may not necessarily be possible from a transcatheter approach or percutaneous approach, I should say. And then what does that PFO morphology look like? Is it a single tunnel? There are cases where we had at our institution at one point a double tunnel. So it's sort of like that septum primum is tacked down in the middle, and now you've got the two tunnels. I'm not sure that necessarily changes the type of device you pick, as long as the tunnel widths are still within a range that a device would cover. But certainly sort of that environment around the PFO and septum secundum ASA are the big things to look at.
Dr. Pinsky.
David Pinsky, one more question. Can you talk a little bit about workflow? For instance, can this all be done preoperatively, or does it require the physical presence of an echocardiographer in a room during the transcatheter closure? It just is a lot of people and a lot of effort when it's needed simultaneously.
That is a wonderful question. So this can be done preoperatively if you're trained to see and get the right dimensions. I will say because of hemodynamic changes, sometimes intraoperatively things look different. The way that I have been used to seeing and, over the last year been trained at my prior institution was at the time of closure, we do have an echocardiographer who interrogates or reinterrogates the septum. It's always helpful when there is a pre-op TE that's done, because that obviously allows you to get a better understanding of what that morphology, that environment, and that device size should be going in. But to truly accurately say that, everything the day of the intervention is the same as it was before, it is helpful to have that echocardiography. I will say, however, that I don't think it's totally necessary. If you do have somebody who will make those measurements ahead of time and they have a pre-op TEE, you can still use these parameters and talk with the interventional team ahead of the procedure and say, these are the dimensions that I've gotten. This is the device that I think would be best sized. And then, at least that's another layer and piece of information that everybody has going in. I do know that ICE oftentimes is used rather than, TEE. There are capabilities of ICE to be able to do 3D, of course, but it does become a little trickier given the differences in being able to actually do 3D TEE versus just ICE alone.
Thank you.
Any other question in the audience? Any questions on the virtual audience? All right, Dr. Piech, thank you so much for your time and your education. It was a wonderful talk. Thank you.
Absolutely. Thank you to everybody for your time today.